Good morning, friends and chairpersons. It's a great pleasure to be here with all of you in this beautiful afternoon. The topic of I'm not used to this actually. Okay. My title of the paper is Hydissect, a new surgical technique in the management of complex posterior polar cataract. Friends, and we do not have any financial interest in the subject matter of this presentation. We know that the posterior polar cataract is a surgical challenge due to its associated high incidence of intraoperative posterior capsular disruption. With any routine phacoforceps or attempt to detach the cataractous plaque may lead to complete pre-extraction disruption of the posterior capsule. Various incidences have been put forward, up to 36 to 40% PCR by most of the leading surgeons. And various techniques have been described to deal with the posterior polar cataract: slow motion phaco, step-by-step chop in situ and lateral separation, lambda sculpting and cracking by various authors. And the important point is most of these techniques, they are suitable for the simple posterior polar cataract where you have a posterior capsule intact and it's thin, but it's vulnerable to any kind of forces may disrupt. So these techniques are very suitable for all these cases, but what about the treacherous complex posterior polar cataract with posterior capsular anomaly? Because these are the cases where you have a posterior capsular defect, already existing posterior capsular defect. You may have a rent. There could be a complete adhesion of the posterior capsule with the plaque. So if you have a complete adhesion of the plaque, then taking out that plaque from the posterior capsule becomes very difficult. So the purpose of this study or the technique is to describe efficacy of a new surgical approach, Hydissect, in the management of complex posterior polar cataract, and especially in minimizing the risk of further disruption of the posterior capsule and prevent posterior segment complications, and also in preventing pre-extraction posterior capsular disruption. We took up 22 cases of posterior polar cataract from our OPD during the year 2016 and 17. And on the basis of clinical examination, cases were grouped into two: simple and complex posterior polar cataract. Cases of complex posterior polar cataract were included in this study. Complete preoperative examination, including the biomicroscopy, anterior segment OCT, specular microscopic examination, fundus examination, and as and when required, fundus fluorescence angiography and the posterior segment OCT was done. All the 10 cases of complex posterior polar cataract underwent Hydissect technique. Hydissect, what is Hydissect? It is the bimanual irrigation aspiration cannula controlled dissection, separation, and extraction of the cortical matter, epinuclear membrane, and polar cataractous plaque, simultaneous posterior capsular axis. So here we are not using the phaco probe to directly aspirate as we do normally. With the phaco only, we try to extract the complete complex of the cataractous complex, where you extract that plaque also, and may lead to the complete disruption of the posterior capsule and then the complications. So looking at this video, you can see like we take all the care, all the standard technique to start with the posterior polar cataract, limited anterior chamber inflation, multi-quadrant hydrodissection. We have to avoid the cortical cleaving hydrodissection, and hydrodelineation and the removal of the nucleus with a simple divide and conquer technique, like you just hold the nucleus without putting any pressure on the posterior capsule, take out the nucleus. So these are the standard practice we do in most of the time when we are dealing with the posterior polar cataract. Now the technique comes here. So we are using now the irrigation and aspiration cannula now for the rest of the aspiration of the cortex, epinucleus. And you can see here, what I'm trying to do is I'm removing the cortex and preserving that plaque on the posterior capsule, so that you are basically putting a pressure on the posterior capsule, so that you do not get into the problem of the complete disruption in the beginning itself. So this is the plaque, and then finally, I'm using the aspiration curve, because you cannot hold this plaque with the forceps. It's friable matter. So you have to use the vacuum to extract, and extraction has to be very slow. As you can see, because while extracting this plaque, I'm trying to put some sort of traction on the posterior capsule also, and trying to separate it, and creating a posterior capsular rhexis also. So you can see this is a slow motion, because I have done a lot of this to shorten the video. So you won't be able to see the complete technique, but yes, some part of the technique. And then once you have removed it, and you can see the posterior capsular defect is well maintained without the loss of the vitreous, but this has to be done very slowly with the aspiration cannula only. And these are the cases where so the important point which I want to show here is we did a successful PCC in 9 cases out of the 10 cases. Vitrectomy was required only in one case. In the bag, IOL was placed in 9 cases, and sulcus IOL was placed in 1 case. The visual improvement was excellent in all the cases. So to conclude, Hydissect, bimanual low vacuum controlled aspiration of the cataractous plaque while creating a controlled posterior capsular axis is the most suitable surgical approach in the management of complex posterior polar cataract to prevent pre-extraction disruption of the posterior capsule and to prevent possible potential complications in which we come across with the PCR. Thank you.
Thank you, sir. Only one question I would like to ask. Was there any sign of Daljit sign or a fishtail sign seen in these patients on a slit lamp demonstrating?
I didn't hear. What were you asking?
Did they have a fishtail sign, these patients, indicating preoperatively that there may be a defect onto the posterior capsule, or they just onion peel type of posterior polar cataracts?
See, actually, I've already shown in the first picture. In the first picture, it's very clearly showed. You can see on clinical examination itself with the slit lamp, you can see the defect. If not, then you can confirm it with the OCT. So OCT is the very important, rather than looking at the signs and the onion peel and this. You may not get the complete picture, but if you do the OCT, you will definitely 100% know that there is a PC defect. So in all the cases, OCT was done, and it was confirmed with the OCT only. But in the clinical examination with the slit lamp also, in almost 60-70% of the cases, you can very clearly see the defect.
Right, sir.
Sir, thank you, sir. That's a beautiful technique. And you have magical hands to have done a posterior capsular rhexis without using the viscoelastic to stabilize the chamber, sir.
Yeah, that's
why.
There
is a nice paper from Hong Kong, sir, dividing posterior polar cataracts into 3 groups based on OCT findings. Basically, they came to the conclusion around 5% of them have a pre-existing rent and they have a posterior bulge. Right. So did your ASOCT show any of your patients with a pre-existing posterior capsular disruption and a bulge into the vitreous?
No. So actually, that is what I showed. Only in one case, we lost the vitreous, and there we had to do the vitrectomy and place. That's why I'm saying, because in most of these cases where you have a PC defect and already existing PC defect, the vitreous space is very tight. So this is my experience, yes, because most of them have the tight because it's exposed vitreous. So you have it like what you see post-operatively. If you happen to get the post-PC rupture and the vitreous face is intact, you just see these patients after a month or so, the vitreous face would become much stiffer and hardened.
Yes.
So similar picture you find intraoperatively in these cases where you have a PC defect. The vitreous will not lose unless you try to remove that plaque forcefully under where it is adhered. Then you may have a vitreous prolapse.
Thank you.